are to explore classical osteopathic perspective in relation to fascia, to discuss the value of the long lever approach to fascia and its integration within the body adjustment routine, to relate to fascial adjustment to the applied mechanics models and visceral adjustment, and also to dispel some of the myths associated with adjusting fascia. It was one of the things that I had to do actually researching for this, and by doing this kind of work, it's refreshed my understanding of the way that we're working with fascia, and actually kind of changed and developed the way that I work in practice. Even though I've been working for 30 odd years, um, it's still kind of evolving. And I think the thing with this kind of approach to treatment is that it should continue to evolve. I think our work needs to continue to stay alive, to evolve, to keep working with us. And I hope this will provide some, insights and maybe some inspiration to you um, in your work. So that brings us to, the question that we want to follow up through the next series of lectures. How do we adjust the fascia? If we're saying that, it doesn't stretch very much, in actual fact, beyond the force of, a lion's jaw, um, how do we adjust it? How is our thinking in terms of that? So, firstly, by a series of minor adjustments and releases. So, as we're working through the body, we may not be, teasing out a great deal of, change or, lengthening in the tissues. What we are doing is a series of, minor adjustments through the sort of fascial tissue, through the sort of interrelations of fascia. One of the things that we're going to go looking into in further lecture in this series, the sort of Myers models of the sort of fascial relationships through the body, the interconnectedness of the fascia from one end of the body to the other, and how um, we approach that in terms of our the sort of classical approach of this long lever technique. How we're not just releasing joints, we're not sort of merely releasing kind of fascia, etc. We are trying to integrate these structures, which is again something we'll talk about kind of at length when we get to that um, part of the sort of lecture series. So we're teasing out restriction and fibrosis between the fascial layers. So the way that the a long lever is used, we are trying to relate one area of tissue to another. That leverage should be working through tissues to create separation where there's binding, to address physiologically kind of fibrotic changes by just over a series of treatments, just teasing out the fibrotic changes in the tissues um, in relation to sort of larger movements of the body, in relation to specific joint movements, and in relation to the spine itself. And of course, within that, we're trying to encourage the freedom and the circulation right through the body, particularly from the limbs into the trunk and vice versa. Um, when I started to look into the kind of details of the body adjustment to teach it hopefully better, one of the elements that came up was looking into the sort of circumduction movement and what it is that they're supposed to be achieving, and whilst looking at these patterns of these sort of circular movements. We're looking at releasing tissues in a sequence, in a physiological sequence. So, as in, the body would naturally go through that kind of pattern of movement, and using lever and fulcrum to tease out restrictions, both in more superficial tissues, but also coordinating that with release into sort of deeper structures, deeper tissues, and so on. So, in the use of our kind of leverage modalities, we are slowly working, from one layer to another, um, and working through the body. And again, we'll be looking at that in later lectures in this series. This is from a research talking about stretching improving gait, mechanical sensitivity, and connective tissue inflammation in rodent model. Mechanical input in the form of static tissue stretch has been shown in vitro and in vivo to have anti-inflammatory and anti-fibrotic effects. What they were finding where there are fibrotic changes in fascia, there is also kind of inflammatory response, and by initiating um, release of fibrotic changes through just gentle stretch, this is actually having an anti-inflammatory and anti-fibrotic effect. It's also worth noting in that respect that consequent to that, too much stimulation, too much stretch actually then brought back inflammation. So one of the kind of ideas, one of the concepts in the classical approach is about timing and rhythm and handling, and that is, it's very important that we maintain a gentle approach, even though a long lever it's a very strong means of interaction. It means we can actually use very accurately and very gently, and the very nature of what we're trying to do is having um, an anti-inflammatory and kind of healing effect in the very nature of those leverages and so on. And we see when we look at kind of examples of the classical long lever here, Mr. Wernham's trying to address lesions in this lady's pelvis, anteriorizing the ilium on the left side, but at the same time you see a lovely stretch across the body and from the pelvis into that lower spine, and coordinating the release. It's not just about joint release again. Here we see the leg being used as a lever in the circumduction movement, and teasing a release laterally in the kind of left leg in relation to the pelvis and coordinating. One of the things Mr. Wernham used to say is very often when we take the leg across the midline in patients, that feels very uncomfortable. It feels like pain in the hip joint. In actual fact, more often than not, it's discomfort in the inguinal ligament on the left. And one of the things that Mr. Wernham talked about was the continuity of the tissue through the tensor fascial lata and so on into the inguinal ligament. So we see that kind of continuum of tissue being engaged with that lever, as well as in relation to his right hand as the fulcrum, prizing the left sacroiliac joint open. So again, we're not just thinking about the sacroiliac joint; we are coordinating with the sort of restrictions through the fascia and the continuity into the ligament, so the inguinal ligament. And his way of addressing that discomfort that the patient feels is just taking the lever to the edge of the field of discomfort and just holding and waiting for the tissues to release, and a whole bunch of kind of reactions through the sort of nerve reflex and so on, letting go of that. Like I spoke last time of the stages of kind of evolution of a condition, from sort of volitional to sort of voluntary to kind of postural fibrotic changes and reflex changes and so on. So we're taking the patient back through those stages just with that static hold in that case. It's a very interesting part of our kind of release, and very often you'll find if you don't have that sort of the patience of that kind of approach, that you'll never really resolve the sort of really deeply embedded lesion pattern that is in the pelvis, particularly on the left side. And I'll explain a little bit later why the left side is affected and how it's affected. When Littlejohn talks about the effects of the osteopathic lesion and injuries, traumas, the effects of posture and so on, he says that the residue, the sort of long-term effect of distortions and so on, resides in the fascial tissue and ligamentous tissue. So very focal to our work, considering the adjustment of the fascia. And as I said, from the word go, there isn't much give in the fascial tissue itself. So we're getting a little bit of release, but a lot of it is about sort of just moving it, freeing it around, coordinating sort of restriction and freeing one layer from another, and coming back to the spine or sort of joint structures as the fulcrum point around which the sort of fascia is tethered and around which it moves. So that's what we're kind of building on today. So we see he starts, from the soft tissues. He starts from a sort of distance, and he works in, comes in to make contact. He's feeling the soft tissues. You see him using the back of his hand at one point, which is much more sensitive to temperature changes and temperature and humidity. So we're looking for the sort of involvement of the sympathetic system, but also we're getting a feel of that kind of web of the fascia, if you like, and how it relates to both the sort of spinal architecture and also to movement, how symmetrical the movement is, how the movement relates from one curve to another, and so on. And we see that separation in Mr. Wernham's arms. That can also be directed to localize traction into a particular part of the spine, a combination of torsional leverage, the leverage and weight of the leg acting as a sort of pendulum leverage, if you like, and then the movement through your arms can actually localize traction into specific parts of the spine, usually from sort of D9 downwards, um, to assist the sort of overall release rather than just specifically, again, dealing with the pelvis. So again, part of this whole sense of the long lever approach uh, is the combinations of movements that it can bring into play, rather than just specifically releasing a particular tissue.